Hello and welcome to today's lecture on shock. Today we're going to talk about the underlying physiology of shock. We are going to compare the clinical findings throughout all of the different stages of shock. We are going to look at all the nursing and medical interventions for people with shock, and we are going to look at some of the vasoactive medicines and how we use fluid and pressors to treat shock. We really have discussed shock repeatedly throughout the semester to this point, but today we're going to talk about it as a general concept. Okay, so when we think about shock, we say that shock is a life-threatening condition that has a variety of underlying causes. There are different shock states, but the thing that we know is that all shock states, no matter what the underlying cause, there are three things that they have in common. One, there is hypoperfusion, not enough oxygen and nutrients to meet the demands of the tissues. Two, there is activation of the inflammatory response that we talked about when we talked about sepsis. And three, as a result of that inflammatory response, we have hypercoagulability or an increase in clots. In order to maintain blood flow to the tissues and for the cells to get the nutrients and oxygen that they need, there's a couple things that have to be in place. One, we have to have an adequate pump. The heart needs to be able to pump the blood. Two, we have to have effective vasculature or a circulatory system. So the tubes or the pipes that connect the pump to the tissues need to be healthy and need to be the right diameter in order to circulate the blood. And lastly, we need to have sufficient amount of blood in the right areas in order to perfuse the tissues. If you have a problem with any one of those things, then we compromise tissue perfusion. And if tissue perfusion is compromised and it is inadequate or not treated, then we do not get enough oxygen and nutrients to the cells. The cells starve, they die. When the cells die, the organ is dysfunctional. Then when the organ is dysfunctional, it progresses to organ failure, and then from organ failure to eventual death. Let's talk for 1 second about normal cellular function. Cells need energy to do their job. Nutrients are carried by way of the blood to the cells, and the cells break them down, metabolize them, and they store ATP as energy. Now, in order for that metabolism to happen, the sugar to break down, we can synthesize this ATP aerobically, and that is the most efficient way, or anaerobically, a much less efficient way to produce ATP. In other words, aerobic metabolism yields far greater amounts of ATP per glucose molecule than does anaerobic metabolism. So it's better to have aerobic metabolism than anaerobic metabolism in terms of the amount of energy that it produces. Also remember that anaerobic metabolism produces lactic acid. Okay, I want to spend 1 second here and I want to talk about the pathophysiology of shock. In all types of shock, the cells lack adequate supply of blood. They don't have enough blood to supply the amount of oxygen that they need. So, I'm going to say that again. In all types of shock, the cells lack adequate blood supply and are therefore inadequately oxygenated. That inadequate oxygen leads them to do anaerobic metabolism, producing much less ATP, much less energy. But that anaerobic metabolism also is releasing lactic acid, which makes the intracellular environment acidic. And when that happens, when the inside of the cell has too much acid in there, it causes the cell to swell, and it changes the cell permeability, the membrane permeability. And so fluid and electrolytes are willy-nilly going in and out. And there's a dysfunction for the sodium-potassium pump. And when that happens, there becomes impaired cellular structures, specifically the mitochondria, and these impaired cellular structures become damaged and the cells die. So we said that all shock states have three things in common, and the lack of perfusion, which can result in cellular death, is one. Two, the inflammatory process is engaged. We talked about this last week, or maybe not last week, when we talked about sepsis. And what we said is that we have an increase in the inflammation. We have an increase in fight or flight. That increases the amount of catecholamines and cortisol. We also have that inflammatory response, which is releasing the cytokines. And the cortisol and the catecholamines are creating a situation where we have an increase in insulin resistance. That means that the cells are not responding to insulin the way they used to, and the cells do not get enough sugar, enough glucose, and then they begin to burn fatty acids, and they're making ketones. We also know that as the inflammatory and stress response continues, that the liver, one of the liver's jobs when we have respond to stress and the increase in the catecholamines, is to convert glycogen to glucose. And as the stress response stays in effect, the stores of glycogen become depleted, and then the body has an inability to have enough nutrients for cellular metabolism, and that causes a buildup of those metabolic end products, the ketones, in all of the cells and in the interstitial space. So in addition to that inflammatory response, so we had the hypoperfusion, we had the inflammatory response that is causing an insulin resistance. It's causing cytokines to be released, and those cytokines are causing histamine, and histamine is changing the permeability of the vessels, and the cytokines are causing vasodilation of the vessels. So that changed permeability is allowing the fluid to leak out of the vascular space into the interstitial space. As a result of that inflammatory process, we have a state of hypercoagulability. That means, remember, we have all those blood clots that are sticking to the endothelium. So we have small little blood clots in the microcirculation causing all these roadblocks, and those roadblocks cause hypoperfusion to the organs. And all of those things, the hypercoagulability, the inflammatory response that's causing insulin resistance and causing fluid to leak out of the vascular space, as well as the hypoperfusion, create a state of hypoxemia. And when you have hypoxemia, those increased levels of lactic acid, and when you have increased levels of lactic acid, we increase capillary permeability, and that means that fluid is leaking more into the interstitial spaces, and that's decreasing cardiac output, more and more and more. So when we talk about shock, we talk about two different general classifications: low blood flow and maldistribution. Low blood flow comes from cardiogenic shock or hypovolemic shock, and maldistribution of flow comes from septic shock, anaphylactic shock, and neurogenic shock. We are going to talk about all of these different shock states because that helps us know how to treat the underlying cause. Cardiogenic shock. Cardiogenic shock is something that we really talked about when we talked about heart failure. You can have cardiogenic shock because of ischemia, a major MI, like an anterior wall MI, because you have a major dysrhythmia, because you have heart failure. Cardiogenic shock is probably most commonly related to a massive MI. So when we say cardiogenic shock, we say that the heart does not have the ability to contract and pump enough blood to meet the oxygen and nutrient demands of the tissues. So we said that in order to have a good perfusion, we have to have a pump that works, vessels that work, and blood. In cardiogenic shock, we don't have a pump that works properly. So if I have a pump that is failing and it cannot pump enough blood, we have a decrease in cardiac output. When we have a decrease in cardiac output, we know that is also called altered tissue perfusion. And when I don't have altered enough tissue perfusion, I don't have enough oxygen, I have impaired metabolism, and my cells start doing anaerobic metabolism and building up lactic acid. When we think about clinical manifestations of decreased cardiac output, we start to think that the early signs of cardiogenic shock will look like acute decompensated heart failure. We should think that our person will have tachycardia, a blood pressure greater than 100. We should think that they will have hypotension with a systolic pressure less than 90 or in some sources less than 80. We should think that they might have a narrowed pulse pressure. We would think that their respiratory rate would be up. We think that their O2 sat would be down. We would be looking at their skin, which might be cool, clammy, diaphoretic, cyanotic. We're thinking that they would be in the early stages experiencing poor perfusion to the brain and feeling anxious, restless, and agitated. In the later stages, with decreasing alertness and lethargy and followed by coma. We would think that the urine output would be down. You would think that they would have an elevated specific gravity. We would have a decrease in renal blood flow. We would have, like all compensatory mechanisms, when we do not have blood flow to the kidneys, poor flow to the kidneys, we increase the renin, angiotensin, aldosterone system. And we already saw that we had increased tachycardia because we had the sympathetic nervous system engaged. When we think about the respiratory system, we said that there would be tachypnea, probably greater than 24 a minute. There might be pulmonary congestion and crackles from failure of the right side of the heart. They might be cyanotic. They would have a poor capillary refill. Myocardial oxygen consumption would be up because they are tacking away. And so because that myocardial oxygen consumption is up, we might think that the patient is at risk for angina. When we're thinking about the GI tract, we know that the bowel sounds will be decreased, that they have a decrease in peristalsis, they may have nausea and vomiting, they're at risk for an ulcer or a paralytic ileus. Their blood sugar will be up because their fight or flight response is kicked in and they have an insulin resistance. Their BUN will be up from acute kidney injury early and followed by a creatinine. You might see some mild infiltrates in their lungs, maybe even some EKG dysrhythmias. And then we have to try to fix the problem, fix the underlying cause. And in that regard, we're talking about to limit the amount of damage. We are talking about taking measures to increase cardiac contractility, decrease preload, and decrease afterload. We want to get this person on oxygen. We want to try and keep their O2 sat above 90%. We start with mild measures and progress and become more aggressive as necessary. So you'd put them on a nasal cannula, non-rebreather, rebreather, all the way up to vent support. If the problem for cardiogenic shock is related to ischemia, like an anterior wall MI, massive anterior wall MI, the person might require TPA, thrombolytic therapy, maybe even angioplasty or bypass surgery, maybe even an intra-aortic balloon pump if we have to support the failing pump. And you'll learn about that when we do cardiovascular or critical care concepts. We might even treat any pain that the person has to reduce anxiety. We would treat it with morphine. That would help control anxiety. It will help control the pain. It will also vasodilate the vessels, thus decreasing the workload of the heart. Your patient may be on diuretics like furosemide, Lasix to decrease preload, maybe even antidysrhythmics, perhaps even aspirin or a beta blocker to help decrease the workload of the heart and preserve the cardiac muscle. Many times we need to use vasoactive drugs to restore and maintain blood pressure. And we can use aids like dobutamine to improve contractility. It's a not positive ionotrope, so it helps the strength of the myocardial muscle. Or sympathomyometic like dopamine or nitroglycerin to improve, to vasodilate and to decrease the afterload or the workload of the heart. So these drugs will be used. We will be continuously watching the stability of their heart with hemodynamic monitoring. They might have an arterial line, continuous EKG monitoring. We might have to support them with, like I said, an intra-aortic balloon pump, an arterial line, or a VAD, a ventricular assistive device, all three of which will be discussed when you do critical care concepts. Let's not forget promoting comfort, decreasing anxiety, and maintaining proper position, which is having your patient sitting up to decrease the workload of breathing and improve vital signs. Hypovolemic shock is a decrease in circulating volume, not enough blood, related to external or internal blood loss. So it could come from trauma or surgery, severe nausea and vomiting, diarrhea, excessive diuresis, diabetes insipidus, hemorrhage, burns, ascites, dehydration, can all lead to hypovolemic shock. So when we say that it's a loss of blood, internal or external blood loss, that means that there is a loss of the intravascular fluid volume, not enough blood in the veins. And if there's not enough blood in the veins, there's not enough blood returning to the heart. And if there's not enough blood returning to the heart, preload is down. If preload is down, then stroke volume is down. And since cardiac output equals heart rate times stroke volume, then stroke volume is down, we have a decrease in cardiac output. And when we have a decrease in cardiac output, we have altered tissue perfusion. And when we think about altered tissue perfusion, we think about all of those things that we just said. We think about restlessness, agitation, confusion, progressing to lethargy and coma. We think about cool, pale, clammy skin, diaphoresis. We think the heart rate is up, the respirations are up, the blood pressure is down, the O2 sat is down, urine output is down, GI motility is down, capillary refill is sluggish. All of those things that we just said hold true for hypovolemic shock as well. The goal for hypovolemic shock is to treat them and replace the volume that has been lost. So when there is greater than a 30% loss, we need to replace blood volume. And of course, treat the underlying cause. You know, if there's trauma and that's why you're bleeding, we need to fix whatever is bleeding. Anaphylactic shock is a life-threatening hypersensitivity reaction. It is an acute allergic reaction that needs immediate intervention. So when we talk about anaphylactic shock, we talk about a patient that has antibodies to a foreign substance, and they develop a severe systemic, that's the key, systemic antigen-antibody reaction. So when we talked about sepsis, we talked about an inflammatory response. So when we're talking about anaphylactic shock, we are talking about a systemic inflammatory reaction in which histamine is produced, cytokines are produced, and we are changing the permeability of the vessels. We are causing massive vasodilation. So we have cells, or vascular wall cells, that are allowing fluid to leak into the interstitial space. We have massive vasodilation, and those things can lead to vascular collapse. One of the things that's unique about anaphylactic shock is that it also causes severe bronchospasms, and those severe bronchospasms compromise the airway and can lead to a stridor and wheezing. There you have a picture of hives down the bottom. You see that the person can have swelling of the lips or tongue or angioedema, the wheezing and stridor that we talked about, the respiratory distress from the acute severe bronchospasm, and the circulatory collapse from the vasodilation and the leaking fluid. You might see the patient who presents with sudden onset of these symptoms. When we're treating this, we need to immediately remove the antigen, the bee sting, the substance that they were allergic to needs to be removed. The blood reaction needs to be stopped. If you're giving blood and they have a transfusion reaction, that is. We need to restore vascular tone and stop the bronchoconstriction. So a great drug of choice is epinephrine. Epinephrine, you know, is a catecholamine that produces a sympathetic nervous response. So in a sympathetic nervous response, we will have bronchodilation and we will have vasoconstriction of the vessels. Following the epinephrine, we're going to give Benadryl to decrease the effects of histamine. We'll give albuterol as a bronchodilator to help with the breathing. And sometimes these patients even need to have some cortisone orally or IV after that. Neurogenic shock. In neurogenic shock, vasodilation occurs because there's not a balance between the sympathetic and parasympathetic nervous system. Normally, you have some sympathetic activity and some parasympathetic activity. One vasodilates, one vasoconstricts, and it kind of keeps us in check so that we have a normal blood pressure. When we have neurogenic shock, not to be confused with spinal shock. Spinal shock is different. You'll review it when you do spinal cord injuries, but spinal shock is flaccid paralysis below the level of the injury. It's the absence of all voluntary and reflexive activity below the level of the injury. So that's spinal shock. Neurogenic shock is not spinal shock. It can occur because of a spinal cord injury. It often occurs within 30 minutes of a spinal cord injury, especially with an injury that's T6 or above meaning T6 to C1. So with neurogenic shock, we say there is an unopposed vagal response. That means that we have too much parasympathetic activity and not enough sympathetic activity. And so that unopposed vagal response, too much parasympathetic activity, causes vasodilation and causes pooling. And so that vasodilation and the pooling in the vessels produces a profound hypotension, and the blood volume is stable, but we just can't, there's such drastic dilation that it causes a relative hypovolemia, and we can't get enough blood back to the heart. And when I can't get enough blood back to the heart, I don't have enough stroke volume, and therefore cardiac output is down, and it can lead to profound altered tissue perfusion. And when I have the profound altered tissue perfusion, I am going to cause, it can last for a couple days, couple weeks, up to 6 weeks long, but the skin is cool and moist, and I have hypotension and bradycardia, which is usually different because usually we might have hypotension with tachycardia, but in this instance, sympathetic response is down so that I have bradycardia. What are you going to do? Well, we need to mobilize those fluids, so we might use compression stockings. You might elevate the foot of the bed to minimize pooling of the blood in the legs. But because the blood is pooling, they're at increased risk for blood clots. So you're going to want to really be careful and look for signs and symptoms of a blood clot, like pain, redness, tender, unilateral edema, meaning one leg is swollen and not the other, a calf that's warm. So it's going to be very important that you're performing passive range of motion. Certainly Lovenox is indicated here. Septic shock. I'm only going to spend 1 second on septic shock here in this narration because you spent so much time. We spent an entire class period on it. So you'll remember that septic shock is sepsis, the presence of sepsis and hypotension that persists despite fluid resuscitation. And we are beginning to see signs and symptoms of altered tissue perfusion. Just as a reminder, we have the increase in the inflammatory process, which causes increase in coagulation, and we have those little microclots that are forming and causing maldistribution of blood. We have hyperventilation, tachypnea, difficulty regulating our temperature, decreased urine output, restlessness, agitation, confusion, a decrease in peristalsis at risk for an ileus or an ulcer. We have oftentimes sepsis leads to ARDS, where we have acute respiratory distress, where we have hypoxia, and we have a VQ mismatch. No matter how much oxygen we give them, the oxygen is not going up. We have that surfactant dysfunction, which is causing atelectasis. The 4 stages of shock: the initial stage, the compensatory stage, progressive, and the refractory stages of shock. Turn the slide. In the initial stages of shock, the thing is that shock is progressive. It kind of works along a continuum. It can be identified very early on, or it can be identified very late. The earlier the interventions start, the early we initiate intervention, the greater chance the patient has on surviving. There's a lot of research right now that's focusing on assessing patients who are at risk for shock in order to determine if they are experiencing a decrease in perfusion before we ever see clinical signs and symptoms. And that's this initial phase. And we're going to talk about some of the newer technology out there to find out who has tissue hypoxia before we ever see signs and symptoms. But what we do know is that current evidence research suggests that treatment needs to be started within 6 hours of the onset of symptoms. So early detection is very important. So in the early stages, we might actually see cool, clammy skin. Heart rate is beginning to climb. Maybe the person's feeling a little apprehension or a little agitated. But lactic acid is beginning. There is some alterations in perfusion. So the lactic acid, not to a great extent, is beginning to accumulate in the body. So the compensatory stage. The compensatory stage is just that. They're able to compensate. Blood pressure remains normal, but in the beginning, blood pressure remains normal. But the sympathetic nervous system has kicked in. It has increased heart rate. It has caused vasoconstriction. The fight or flight response has kicked in. So we have increase in cortisol levels. And when we have an increase in fight or flight and our cortisol levels, you know that we are shunting blood from the skin and the kidney and the GI tract. We shunt it from there to try and send it to the brain and the heart and the lungs where we need it the most. And that's why when you see the skin, the kidney, and the GI, that's why they are early signs that there is hypoperfusion. Because not only is it just not the blood flow getting there, when we have that fight or flight, the body is consciously shunting blood from there, indicating the level of lack of perfusion. So this is the body's attempt to overcome the consequences of hypoperfusion and anaerobic metabolism. And we know that this is when the baroreceptors cause the sympathetic nervous system to kick in and the blood pressure may be down. So we're going to cause vasoconstriction and try and perfuse the major organs. And remember, when we vasoconstrict to perfuse those major organs, that's like that example we use of the garden hose. One with no nozzle, the water just pours out on the floor. If I put a nozzle on and vasoconstrict the opening that water goes through, I can squirt across the room. So we have activation of the renin-angiotensin-aldosterone system because there's decreased blood flow to the kidney, and we're trying to hold on to sodium and water because we're trying to increase venous return and keep cardiac output where it needs to be in this compensatory phase. If we're able to correct the deficit at that point, the person will probably recover. If we are not able to correct the problem, the patient is starting to transition from the compensatory into the progressive stage of shock. I'm sorry about that. So as the patient starts to transition, we start to see more and more we're not able to compensate, and we start to see signs and symptoms that there's altered tissue perfusion. The skin is cool and clammy and cyanotic. The blood pressure is falling. The pulse is very rapid and weak. They're breathing really quickly. They're restless, agitated, and confused. Their urine output is down. They're at risk for developing an ulcer and a paralytic ileus. Bowel sounds are down. And we're really watching blood pressure. We're watching blood pressure because we're looking for a drop in blood pressure that has a systolic pressure less than 90, or a drop of 40 millimeters of mercury or more. We're looking at a mean arterial pressure of less than 65. And we're watching pulse pressure. Pulse pressure is really important. Pulse pressure correlates to stroke volume. And stroke volume correlates to diastolic pressure as well as cardiac output. So pulse pressure is correlated, figured out. Systolic pressure minus a diastolic pressure is pulse pressure. A normal pulse pressure is 30 to 40. So that would be, a normal blood pressure 120 over 80. A pulse pressure 120 minus 80 is 40. So a narrowing pulse pressure is an early indicator of shock. And the pulse pressure will narrow before the diastolic pressure drops. So it's a very early sign that there's decreasing stroke volume. By the time the blood pressure drops, damage is already happening. Therefore, if we're watching the map, if we are watching the pulse pressure, that might be an early sign. Other things that I said before, some new technology that's helping us to determine early signs of shock would be this, your textbook. We are using this in intensive care units now. It's called a sublingual capnometry. And that is like a probe that goes under your tongue, kind of like a thermometer, and it is detecting increased levels of CO2, which would indicate that there's poor perfusion very, very early on. Something that's a little bit newer that your textbook talks about that I have not actually seen in real life, they call it near-infrared spectroscopy, not really sure how to say it. I'm only learning it from your textbook, the Lewis book, the Morton and Fontaine, as well as some other current resources. So this sounds like it is kind of a pulse oximeter for skeletal muscle. It's some sort of an infrared light that shines through the muscle on your hand at the base of your thumb. There's that fatty muscle there, pad. So it's shining through there, and it's able to detect the oxygen transmission to your skeletal muscle. So like I said, it kind of sounds like a pulse ox machine. Some of the other things that we are looking at, the cold, clammy skin and all that, that's important, but we know we are looking at serum pH, because when the pH is less than 7.35, the person is acidy. We are looking at lactic acid. A critical value for lactic acid is 4. When we have a lactic acid less than 7.35 When we have a pH less than 7.35 and a lactic acid greater than 5, we call that lactic acidosis. So that's something that we watch. We also watch something called, we look the specific gravity of the urine for it to be more concentrated. We would see. We also look at something called a base excess or a base deficit. And that's the amount of base that they have to put into a liter of arterial blood in order to get its pH back up to 7.40. So there is usually a base deficit in shock. That's a little bit more complicated, but I do want you to know base excess and base deficit, just that it exists. I don't need you to be able to interpret the results. So if we weren't able to fix the problem in that progressive or initial phase, or compensatory or initial phase, we're going to move into the progressive phase. That's when all those compensatory mechanisms start to fail, and we're seeing all those signs and symptoms that I said at the end of the progressive stage, because it's the end of the progressive stage, forgive me, at the end of the compensatory stage, the mechanisms begin to fail, and we start to see signs and symptoms of hypoperfusion and increased coagulability, and the vessels are dilating and fluid is leaking out, and we are moving into this progressive stage. It is a continuum, so you can't say where compensatory stops and progressive starts. But when I am in the progressive stage, compensation is failing, you're seeing signs and symptoms of altered tissue perfusion. The heart is working really hard and it becomes overworked and it starts to become dysfunctional and it starts to have problems. The pump starts to fail. The inflammatory process is in full gear, so histamine is leaking, is changing the permeability. We have those cytokines and we have all this vasodilation. We have blood clots causing all kinds of roadblocks along the way. We have significant hypoperfusion to the organs. The fight or flight response is kicked in, our stress response that is. So we have an insulin resistance and we have cells that are starving, resulting in cellular death. So in the progressive stage, it's a big vicious circle. And there's a lot of research right now about why some people, when we treat the underlying cause in the progressive stage, some people get better and some people do not. They believe that, each body has a different response. The body's response to shock or the lack of response to shock will determine the patient's survival. Now that makes sense, but they don't know why some people respond once we've treated the underlying cause and others do not. So in the progressive stage of shock, things are getting really bad. The person has general anasarca because we have fluid leaking into the interstitial space. And the fluid leakage affects the solid organs and the peripheral tissues. We have movement from the pulmonary vasculature into the interstitial space. It's causing pulmonary edema. The alveoli begin to fill. There's a VQ mismatch, a surfactant dysfunction. So you say to yourself when I'm saying those things, oh, essentially this person has ARDS, acute respiratory distress syndrome. There is a myocardial dysfunction, so the heart's not working. We said it's overworked. So it might manifest itself as chest pain or dysrhythmias. At the end, it might result in complete deterioration of the cardiovascular system. We know with the GI tract that there can be ulcers and bleeding, and peristalsis is decreased. In the small intestine, the mucosa can become necrotic, slough off, and cause bloody diarrhea. The patient's at risk for translocation of bacteria. That's, remember we talked about those toxins that enter in the bloodstream through the lymph system. We could have acute tubular necrosis resulting in acute kidney injury, especially if we have a MAP less than 65. So you would be watching for BUN, creatinine, and GFR. BUN would go up first, followed by the creatinine. GFR would be dropping. You're looking for all the fluid and electrolyte shifts that we discussed when we talked about acute kidney injury. We would be talking about a urine output of less than 30 per hour, or 0.5 kilograms per hour. 0.5 mLs per kilogram per hour, that is. When we talk about the liver, we talk about a decrease in blood flow to the liver that impairs the liver's ability to perform its metabolic functions as well as its phagocytic functions, because the liver has a lot of, pulls out a lot of germs. So decreased blood flow damages, so we are at risk then and more susceptible for infection, because the liver fails to filter out the bacteria because it's lost its phagocytic functions. The liver, when it has decreased blood flow, has less ability to metabolize the medications, and wastes start to build up. The things that the liver normally removes, like ammonia and lactic acid that was building up in all those cells that are doing anaerobic metabolism. So all those acids begin to build up in the cells and in the interstitial spaces. And remember, when it's acidy, it changes the permeability of the capillaries. And when it changes that acid changes the permeability of the capillaries, and it is causing the fluid, more fluid, to leak into the interstitial space, further decreasing the amount of circulating volume that the patient has. So the person, because the kidney is also responsible for a lot of clotting, also think that the person's at risk for DIC, that thrombohemorrhagic disorder, in which there is all those microemboli that have formed inside the vessels, and the platelets are all used up, such that if we have an injury or something that needs platelets, we don't have enough. So to prevent the person from moving from the progressive to the refractory or the irreversible stage, we want to treat all along, even in the initial and in the compensatory phase, we're trying to treat the underlying cause. But in this progressive phase, we are trying to use IV fluids and medications to restore tissue perfusion. We are trying to optimize intravascular volume, make it just the right amount, whether it's from cardiogenic shock and they have too much circulating volume, or because of hypovolemic shock because they don't have enough. We want to optimize intravascular volume. We want to support the pumping action of the heart, so increasing contractility is important. We want to improve the competence of the vascular system, so we want to correct that massive vasodilation. We want to support the respiratory system, whether it's oxygen via nasal cannula all the way up to vent support. We want to provide early enteral feedings and nutrition to prevent an ileus and prevent bacterial translocation. We want to make sure we have allowed hyperglycemia. So we want, with insulin and dextrose, we want to control blood sugar and keep it. Current evidence suggests that we should maintain between 140 and 180. We will want to be given histamine blockers or a proton pump inhibitor. We want to prevent complications such as vent-acquired pneumonia, VAP, or infections in the arterial lines, central monitoring devices. We will talk about VAP and ventilator settings and ventricular assist device, intra-aortic balloon pumps, arc lines, all that when we do critical care concepts. We want to promote rest and comfort, treat pain and anxiety, and control temperatures. We want to make sure that we're there to support the family, because towards the end of the progressive phase, the person is moving into the refractory phase. And in the refractory phase, we have refractory or irreversible stage of shock. We have lots of lactic acid accumulation. The capillary permeability is just leaking fluid everywhere. We have profound hypotension, lots of poor tissue perfusion, and we have cellular destruction. We have cellular destruction so severe that death is inevitable. So, profound hypotension, despite the fact that we are using fluids and vasopressors. Severe hypoxia because they are unresponsive to oxygen. Remember, they have a VQ mismatch and a surfactant dysfunction. Worsening tachycardia. Decrease in coronary blood flow resulting in ischemia to the heart and chest pain. Cerebral ischemia, which is the ultimate cause of death. We have a decrease in blood pressure, which is that profound hypotension, which is resulting in anuria because we have a renal shutdown. Failure of one or more organ systems affects others. Recovery is unlikely in this story. And we have to remember that we have profound altered tissue perfusion, which is causing cerebral ischemia. The cerebral ischemia eventually becomes so bad that we fail to stimulate the sympathetic nervous system, and then we have respiratory and cardiovascular arrest. The cornerstone of shock treatment is volume expansion and vasopressors. We expand with blood or colloids, and we give lots and lots of volume, high amounts of fluid. Let's have a word about giving blood. When we give blood, we use a large bore needle. We use special tubing, and we run saline, not dextrose, when we're giving blood. You have to stay with your patient for the first 15 minutes. We're doing vital signs every 15 minutes. We're really watching the temperature, and we're looking for indications that the person is having a transfusion reaction. If they have a transfusion reaction, stop the blood. Remember, when somebody has an anaphylactic shock, we have to remove the agent. So stop the blood and start running in your saline. So we give fluids to expand the volume, and if that doesn't work, to maximize intravascular volume and blood pressure, to achieve a MAP greater than 65, then we're going to give vasopressors. Vasopressors such as epinephrine or dopamine, norepinephrine, all those types of drugs go on a pump. They require continuous blood pressure monitoring. A cuff is on them and taking a blood pressure every 5 to maybe 15 minutes. Lots of times when we are giving vasopressors, we also have vasodilators because we're trying to keep our patient hemodynamically stable. And so we are titrating them to the exact right blood pressure. So if the blood pressure drops, you're going to decrease the amount of vasodilators. If the blood pressure increases, you're going to decrease the amount of vasopressors. But you would have very clear guidelines to how you are titrating that medication. But when our patient has shock, we are monitoring their vital signs. We are monitoring their output. We are keeping the head of their bed flat. We might even elevate their feet. All medication go IV, nothing goes IM or PO because they have altered absorption. We need to keep our patient warm, we need to monitor the labs, and of course, like I said, we need to support the family. Airway, breathing, circulation. This is the cornerstone. We talked about everything that we need to do. Airway and breathing. We support their respiratory system with the least aggressive form of oxygen therapy possible and as aggressive as we need to be, including vent support. We want to keep the O2 sat greater than 90. In the progressive stage, in the refractory stage, the person's probably on a ventilator and they have ARDS and they will probably need a high PEEP. More than likely have high PEEP. Circulation, we are trying to keep the blood pressure with a mean arterial pressure greater than 65. We're providing pressors, or fluid first, always fluid, and then pressors. You never give pressors before fluid because you need something to press. You need fluid to circulate. So you give fluids, followed by vasopressors. We give drugs like dobutamine, that's a positive ionotrope, to increase the contractility of the heart to help that failing pump. I think that's it. That's 57 minutes of shock. If you have any questions, please don't hesitate to ask. I'm always available. Thank you for your attention.